So a couple of our presenters weren't available to be here this afternoon to talk about their posters. One's on vacation in Kauai, or Maui rather, and the other is actually writing an exam at SFU. So they've both graciously provided some audio clips that will summarize their posters, and their posters are here. And then we have our other presenters as well that will give us a summary about their posters. So.
Hello everyone, my name is Kyle Noftel and I'm an epidemiologist at the BC CDC. Unfortunately, I wasn't able to give this presentation in person, so while you're soaking up immunization information today, I'll be hiking up a volcano or whale watching or snorkeling with sea turtles in Hawaii, so I hope you'll forgive me. So I'm here to talk about the increased measles activity that was observed in BC last year in 2019. So there was a global increase in measles incidence in 2019, and BC experienced multiple importations. In the first 2 months of 2019, BC reported more measles cases than in each of the years 2015 to 2018. In response to this observation, a provincial measles catch-up campaign was initiated. So this poster describes the epidemiology of the 2019 measles cases, summarizes the clustered events, and reviews the impact of the measles vaccine campaign. 31 confirmed measles cases were reported in BC in 2019, 15 imported cases, and 16 locally acquired. Importations occurred from Vietnam, the Philippines, the United States, and other countries in Asia. These were older than locally acquired cases, and only 13% were up to date with measles immunization, compared to half of locally acquired cases. 10 of the imported cases did not result in secondary transmission. 3 importation events involving 6 cases total, however, did result in local transmission. The first cluster involved 13 cases spanning Vancouver coastal and Fraser Health regions and began with 3 co-primary cases returning to Vancouver following travel to Vietnam. Subsequently, there were 3 generations of transmission in a school setting, a hospital, and amongst household contacts. There were 2 additional unrelated clusters occurring in the year. One in Interior Health with 2 cases total, and one in Vancouver Island Health with 6 cases total. In response to the measles activity, a provincial catch-up campaign was conducted in April through June. Over 25,000 measles-containing vaccine doses were administered to students, more than double that administered over the same time period in 2018. The proportion of students across BC with 2 or more documented doses rose by 3% to 82%. With a corresponding 2% decrease in the proportion of students with missing information about their measles immunization status. So there are a few key takeaways here. First being the vast majority of imported cases were either unimmunized or had no documented records of receiving measles vaccine, highlighting the need for those traveling to ensure measles immunization. Secondly, despite multiple measles importations and declining childhood MMR series completion rates, sustained or widespread transmission of measles did not occur. Lastly, the greatest contributor to the increase in students with 2 documented MMR doses was the submission of immunization records of prior vaccine receipt to public health. Missing vaccination records can delay public health management during measles outbreaks and can lead to the potentially unnecessary exclusion of individuals from schools or some workplaces. These events and observations led to enactment of the vaccination status reporting regulation in BC. Hopefully you'll take a moment to review the poster, and if you have any questions, I'd be more than happy to respond to them when I'm back to reality. Thank you.
Great, thank you. Next we have Ellen Gilbert, who's going to introduce 2 posters. Yes. And Ellen is here visiting us from Manitoba.
A little cooler there. Thank you. So I'm going to speak to the 2 posters that we brought. I'm a policy analyst at Manitoba Health, Seniors and Active Living. The first one that we have is our, we're doing English first? Okay, just flip that.
That one's first on our list. So.
It's all good. It's all good. Okay, so Manitoba has the highest per capita rate of immigration in the country. In 2017, over 14,000 immigrants chose Manitoba as their permanent place of residence, and that represents 5.1% of total immigration to Canada. By definition, those who have been in Manitoba from birth are considered continuous residents, while those who have not been or remained in Manitoba from birth are considered non-continuous residents. When we look at Manitoba's immunization coverage rates, non-continuous children have lower immunization rates than the continuous children, although rates for all Manitobans, regardless of residency status, needs improvement. For age 17, only 28% of the non-continuous children have all their polio vaccine doses, compared to 93% of continuous children. So for this project, a team was created that consisted of various stakeholders who work with newcomer populations. The team looked at coverage data from our provincial immunization registry, cohort analysis, the patient journey around seeking health services in Manitoba, and frontline experiences. Surveys were conducted with newcomer populations, the RHAs, and other Canadian jurisdictions. A literature review was also conducted on the immunization coverage differences in newcomer populations, barriers that exist in these populations around immunization, and programs or policies that were in place to improve immunization rates. A couple of the key points that came from the project: the older the child is at registration, the less likely they are to have all their required immunizations in the registry. Newcomer populations from other countries are typically very accepting of immunizations, and coverage rates may actually be higher than they appear, as many newcomers have immunization records when they arrive in Manitoba, but there's no consistent process to collect and record them in our registry. An objective of the project team was to identify barriers and gaps that could be causing the lower coverage rates in this vulnerable population. The gaps identified include differences in provider models between rural and urban RHAs, lack of access to health services or knowing where to go, data process gaps with immunization records, and lack of information on the immunization program for newcomer populations and healthcare providers as well. These gaps resulted in 12 recommendations that vary from systemic improvements in consistent immunization services, collection of records, language services and translation, and communications about immunizations to healthcare and other service providers for the newcomer population. The implementation of the recommendations will begin with the assistance of the project team, and evaluation will occur to monitor the immunization coverage for the newcomer populations in Manitoba. So, thank you. That's the first one. And are we doing, oh, there it is. Yeah. Okay. So this is the second poster presentation, and for this one, across Canada, provinces, territories, globally, we know immunization rates need to be improved. In our current state, we see vaccine hesitancy, and its many facets influencing immunization rates both provincially, nationally, globally. In Manitoba, we found our immunization rates traditionally reported provincially or even at a regional level, disguised within region local variation in immunization rates, and could give the impression that maybe things were not as bad. Our CDC branch had done some previous GIS mapping work with measles back in 2016, and it mapped immunization coverage rates for measles in children below 7 years of age in one of our health regions. This pilot demonstrated the value of both FIMS, our Public Health Information Monitoring System, and ArcGIS as a tool for public health. So any data with a geographical component can be mapped, and the maps provide an intuitive and impactful way to communicate data to an audience. The maps or tools were used for the identification of areas with unimmunized or underimmunized populations, and to help identify local level reasons for the rates. Subsequently, the Manitoba Childhood Immunization Rates Mapping Project began and expanded on that process. So unlike the pilot, where we looked at measles in children 7 years of age in one RHA, the expansion of the project included mapping of coverage rates for pertussis, HPV, rotavirus, and measles at select ages by geographic district in all 5 of the regions of Manitoba. By evaluating the coverage rates for these 4 vaccines, it allowed us to assess immunization rates in 4 different age groups across the spectrum of the childhood immunizations, based on Manitoba's routine immunization schedule for these vaccines. And in addition, it allowed us to assess 2 of the recent changes that we had to our publicly funded immunization program, which was the addition of the rotavirus vaccine in 2014 and HPV vaccine for boys starting September 2016. And by shifting the discussion to local district level, local level strategies could be developed, tailored, and implemented, as opposed to the one-size-fits-all solutions at the regional or provincial level. And then this project would then serve as a base for comparing immunization rates over the years. So our approach, as I say, was to present the immunization coverage data in a different way, reporting at the district level, which is a 10,000 population geographic area. And it varied slightly in the Winnipeg region. Just there's a little bit more variability within the neighborhood clusters in population. So the district rates were displayed visually on the RHA maps. As you see, we created many, many maps. We looked at unimmunized, partially immunized, completely immunized across the regions, across the 4 antigens. We also were able to do a map that would compare year-over-year uptake or changes in uptake of a particular antigen. Then we held knowledge exchange forums in all the regions, 1 or 2 forums where we had a broad range of healthcare providers, managers, physicians, pharmacists, frontline workers, and schedulers, immunization coordinators. And we shared the data maps to initiate a dialogue with the providers who had a more intimate understanding of the local level population to help identify the local drivers of the low immunization rates, and then brainstorm, develop, and implement some local interventions to try and improve those. We were challenging the providers to rethink their approaches and put the focus on the children who were not fully immunized. So we have worked with the regions to monitor and evaluate the implementation of each local level intervention strategy. And now we're in the final phase of the project where the evaluation phase is, and we're repeating our mapping process to assess for any changes in the vaccine uptake at the end of the project period, as well as assessing the outcomes of each of the intervention strategies that were implemented. We'll then be generating a set of recommendations for future programs, and that's all to meet the goal to tailor our local intervention strategies to increase vaccine uptake in children in under-immunized areas in Manitoba. Thank you.
Next, I'd like to ask Rabina Duncan from the Vaccine Evaluation Center.
Good afternoon. It's my pleasure to show some interim results of the QUEST study, and QUEST stands for the Quadrivalent HPV Vaccine Evaluation Study. So, as Dr. Ogilvie primarily indicated, that based on the BC Gov-1 study, which was performed here in BC under the lead of Dr. Simon Dobson, non-inferiority immunogenicity was shown for a 2-dose schedule compared to a 3-dose schedule given in women, and therefore globally 2-dose schedules are recommended as of 2014. The aim of the QUEST study is to monitor the long-term effectiveness of this 2-dose schedule in comparison to a 3-dose schedule of the quadrivalent HPV vaccine against persistent HPV infections at the cervix. For this study, 5 Canadian provinces are working together in a pragmatic trial, and recruitment of the study was done between 2012 and 2018. And girls are included if they have received either 2 or 3 doses of the HPV vaccine, and that schedule was dependent on the provincial recommendations at that time. So here in BC, girls both who have received either 2 or 3 doses are included. Within the study, girls are followed up from 60 months to 120 months post-vaccination. And on a yearly basis, we collect 2 vaginal self-swab and on a yearly basis, a survey in all of our participants. In a subset of the participants, who were also part of the BC Gov-1 study, at 60 months and 120 months post-vaccination, we also asked them to come in for a blood draw so we could study long-term immunogenicity of the 2 and 3 dose schedule. For the interim analysis I'm presenting here today, we performed a logistic regression to compare the characteristics of our 2 and 3 dose participants, and we looked at the immunogenicity after 2 or 3 doses of the quadrivalent HPV vaccine up to 10 years post-vaccination using the competitive Luminex immunoassay. So in total, 5,861 girls are included in QUEST. And compared to the 3-dose participants, 2-dose participants were slightly younger during follow-up, but after adjustment for age, 2-dose participants were still slightly more likely to be born in Canada or having a First Nations background. We also looked at the sexual health behaviors in our group and also adjusted this for possible differences between the ages in the two groups. For the sexual health behavior studies in our study, which were aligned with the Adolescent Health Survey from Macquarie, we didn't find any differences between the 2 and 3-dose participants. If we looked at the GMTs in our 2 and 3-dose participants, we found that the GMTs after a 2-dose schedule were non-inferior to those in a 3-dose schedule, except for HPV-18. But as Dr. Ogilvie earlier indicated, if we compare them to 3-dose women, in which efficacy was shown, the GMTs after both 2 and 3 doses were all non-inferior for all the 4 types included in the vaccine, underlying the long-term protection or long-term immunogenicity of the vaccine. We also looked whether we could observe an increase in the antibody responses in our participants, and we observed such an increase in 23% of our participants. And that increase was measured as an increase above the assay variability cutoff. And this might be an indication for natural boosting due to exposure for HPV or an enhanced response of the immune system. And we are planning to look further into that by linking the HPV DNA status of our participants to the immunogenicity results. So the conclusions is, although this is not a randomized trial, the characteristics of our 2-dose and 3-dose participants seem fairly comparable. Our study so far has demonstrated the long-term immunogenicity up to 10 years of both the 2 and 3-dose vaccination schedule. And the final results of the QUEST study are expected for 2023, but in the meantime, we expect several interesting interim analysis, and the QUEST provides a great platform of young adolescent women who are very eager to participate in research, and we will deliver it as such. Thank you.
Thank you. Kathy Chilton from BC CDC.
Thanks. So as we know, the World Health Organization included vaccine hesitancy as one of the top 10 threats to global health in 2019. Hello, my name is Kathy Chilton, and I'm the vaccine educator at the BC Centre for Disease Control. And as we heard earlier today, vaccine hesitancy has become an increasingly complex challenge for healthcare providers. And according to recent literature, healthcare providers need the support and resources to address common concerns and the growing misinformation about vaccines. And in BC, we have such a resource. It's called the Immunization Communication Tool for Immunizers, or ICT for short. It was last updated in 2013. Since the last update, more literature has become available that emphasizes how healthcare providers communicate about vaccines can significantly impact an individual's decision to vaccinate or not. A survey was recently conducted with BC immunizers to gain a greater understanding of what healthcare providers need to support them to address vaccine hesitancy. The survey findings showed that 93% of the respondents use the current ICT in their practice. Further survey results indicated that healthcare providers want the ICT updated with additional content on vaccine hesitancy and on current vaccine misconceptions. With support from the Professional Education Working Group and the BC CDC, we began the ICT project in the fall of 2019. The focus of the revision was not only to update the current resource, but to include additional content based on the survey findings, and recent literature. In particular, the revision will include additional content related to vaccine hesitancy and a new communication framework to further support healthcare providers. The ICT project team includes 2 contractors who are subject matter experts, a research analyst, a graphic designer, and other subject matter experts for the additional content. The next steps include reviewing the draft version with the ICT with the Professional Education Working Group and making any necessary edits based on their feedback. Final review will involve other subject matter experts and the project team. The poster presentation will highlight the survey results, the content that will be added to the new version, and information on the new immunization communication framework. So if you have any questions, please come by our poster and we'll be happy to provide any information that we have available. Thank you very much for your time.
Thank you. And now the other audio recording, please.
Hi, welcome. I'm sorry I couldn't be there in person today. As you're hearing this, I'm sitting for one of my last midterms as an MPH candidate at SFU, so thank you for showing interest in our poster. Let me give you the general idea of what we did. The first thing to introduce are adverse events following immunization, or AFI reports. These are reports that get funneled into BC CDC every time an adverse event gets reported following an immunization. The second thing to introduce are seriousness criteria for AFIs, but in the interest of saving time, they can be found in the last bullet point in the background. So, all adverse events, serious or not, are reported using categorical event codes, which are grouped into 4 major categories, the last 2 of which are neurological events or other defined events of interest. Now, these are important because they also have an other text field, which is a text box where reporters can give details about an adverse event that doesn't already have a categorical checkbox or event code. The problem with these other fields is that they do not lend themselves readily analyzable by the system, which hampers signal detection and identification of clusters. This was the focus of the first part of the project. As for the second part, we wanted to use surveillance data to test the quality of what gets included in AFI reports that meet seriousness criteria for causality assessment. To do all of that, we collected all AFI reports that were reported under neurological events or other defined events of interest in 2017 and 2018. Reports that met seriousness criteria were reviewed to assess public health recommendations made and evidence of a determination of a causal relationship of the event to the vaccine or immunization. Now, looking at the bottom right-hand corner of the poster, you'll find 2 tree maps. The top tree map shows the 229 adverse events reported under the other text fields. In the interest of saving time, let's focus on the important boxes. Now, those are severe vomiting, severe diarrhea, hematochezia or bloody stools, and anesthesia paresthesia. The other boxes represent events which were either not commonly reported or did not meet reporting criteria in BC. A new version of the AFI reporting system was implemented last year at BC CDC with newly added event codes. Now, the bottom tree map shows the same events but funneled through the new updated system with the new event codes. The overall number of events reported under the other text fields dropped to 113 events, and then most reported events did not meet the reporting criteria. So what this shows is that these new event codes could have reduced the need for reporting in other text fields by 42% had they been available in those years, and the following years could potentially see lower numbers as well. Now, moving on to part 2, the top bar graph in the middle shows that about half the serious AFIs reported in the Vancouver Island and Northern Health Authorities either did not include causality assessments or did not update pending causality assessments. The bottom bar graph shows that Fraser Health has the most thorough standards for reporting details of causality assessment in AFIs, while most other health authorities include either a relatively detailed amount or minimal to no details about causality assessment in AFI reports. This shows that overall, opportunities exist for adoption of a more standardized approach to causality assessment for serious events. Thank you for your time. Enjoy the rest of the forum.
Okay. And we have one additional poster from the Provincial Public Health Information Systems team. It's an information poster about recent immunization registry initiatives, and Elizabeth Lee will be in the lobby to answer any questions that you might have about that poster.